Good morning, dear colleagues and friends. It's a great honor to me to be here today. I'm happy to see here so many, I'm happy to see so many friends here today. And today is my second visit to United States. The first was, I came to United States 9 years ago through a 10-day open world exchange program. We visited hospitals and university in Florida. When I returned in my home to my ENT practice, I told myself, either I must change the country where I live, or I must do something so that Ukraine change and become a place people want to live. A month later, I joined the team at the Ministry of Health, led by Uliana Suprun. There I met people I had known since the Maidan in 2014, and we all had the same motivation. We wanted our country to get better, and we have kept the motivation to this day. Today in this hall, I saw people with the same motivation. You wanted Ukraine to become better, but you are better than us because you lived in the most powerful country in the world, but you still give your time and efforts to help Ukraine. Therefore, first of all, I would like to express my deepest gratitude to you for your continuous support during this difficult time, or for your ongoing efforts to develop healthcare in Ukraine have made a real and lasting difference. I wrote my remarks for the first time in 9 years. I prepared like this, and I apologize for my pronunciation because I might mix up to words that sound very similar in English, like sheep and ship. So I'll read my speech. Okay. History shows that war accelerates medical progress. The same happened in Ukraine. We had to change quickly and base decisions on the real needs of the front. We haven't changed everything yet. We are moving toward a new services architecture. We lack clear pathways, some segments are overloaded, and quality is uneven. The patient care is organized as a continuous pathway, starting from the initial presentation and stabilization through specialized treatment and onto rehabilitation. Along this pathway, we were able to identify the key challenges at each stage and focus our efforts on addressing them. To achieve this, we followed 3 main principles. First of all, time is crucial. Every minute between injury and the first qualified medical aid can determine survival and long-term outcomes. For the most severe patients, our goal is to bring the specialized care they need as close to them as possible. The second principle is coordinated triage. Decision-making for patients with severe trauma should not rely on conventional bureaucratic referral scheme. Instead, patients should be direct straight to the hospitals that have the capacity and resources to manage their specific condition. The third principle in standards and data. And this concept is fairly new to Ukraine. We aim to implement standardized protocols and algorithms and to build patient registries so that the quality of care becomes consistent and no longer depends on chance. This approach will help us identify weaknesses, scale up best practices, and continuously improve the system. I would like to share some examples of solutions that we have managed to implement. Let's start with the blood transfusion at the pre-hospital level. US data shows that 24% of all pre-hospital deaths were potentially survivable, and 90% of them were caused by acute hemorrhaging. Ukraine hasn't yet completed update war mortality reviews, but the signal is clear. Uncontrolled bleeding is the leading preventable cause of death. Logic: resuscitation should start at the point of injury, hence whole blood transfusion begins in the field, before hospital care. This is experience of the United States and Norway. Where we changed, what we changed like the Minister of Health and Government. In 2022, national pre-hospital standard that explicitly allows transfusion before hospital. 2023, permission for trained combat medics without a formal medical degree to transfuse, expanded training network, supply chain. Civilian blood services provide near-front availability of blood and components. In practice, when evacuation is suspended, blood goes to the patient. There is the video of Corpus Azov, drone delivery of blood. It was in March 2025. 2 units of O negative and plasma delivered to the positions. Our defenders was injured in the neck, and without blood they will not be survived. And only these efforts from these guys give them survival.
На позиції була скинута 2 одиниці еритростатної маси, 1 одиниця сухої плазми крові, яка заздалегідь була підігріта.
This is plasma and blood.
Всі інструменти для маніпуляції я в обшукі провів перевіряв.
And this guy which performed, this guy which performed blood transfusion is without any medical degree, and he performs this under telemedical consultation through WhatsApp from medical staff in this brigade. So transfusion in trench sustained the patient until evacuation. Azov were early adopters and helped advocate for allowing combat medics to transfuse. Ministry of Health role is a legal framework, training standards, and integration of the civilian blood system with military structures, so that pre-hospital transfusion becomes standards where it saves lives. Why it's crucial in war? In civilian setting, a patient might reach hospital in 15 minutes. In war, evacuation can take hours or days. Delay costs lives. Timely whole blood transfusion buys the most valuable resource, time to reach the nearest hospital. Our goal: blood in the first minutes, skill in every unit, and logistic closer to positions. The next block is target medical evacuation. This is a change of paradigm. If early the road of wounded person was dedicated by logistics, where is closer, where there is a vehicle, where it's customary to take. Now we put clinical necessity at the center and provide a tool to implement it. Why is targeted evacuation important? Let's look at the typical example of patient hospital road after the injury. First, they go to Mechnikov Hospital in Dnipro for 5 or 7 days. Then in regional hospital in Cherkasy, also in Vik. Then the regional hospital in Vinnytsia. They naturally receive repeated interventions, complications, and get infected with multi-resistant bacteria. and only after this they are referred to the specialized hospital Shalimov Institute, which specialized on liver surgery. The patient now has a higher risk of sepsis because the time has been lost. When we saw the scale of such needs in the road and the consequences, including in terms of infection control, we decide to engage more actively precisely at the hospital stage. The answers of targeted evacuation is simple. A severely ill patient should end up not just in the nearest, but immediately in a specialty hospital where there is a team and readiness to save an ICU, reconstructive surgery, the necessary equipment, multidisciplinary interaction. For the same liver injury, this means delivery to Shalimov with the first 24 hours, further intermediate stops, further infectious complication, and more chance to return person to life and functioning. How it works in practice? First, initiation. The request for targeted evacuation is initiated by the military medical service at a forward surgical node or at near front hospital. There are clear clinical indications, type of injury, risk, stability of condition. Second, coordination. The Ukrainian Center of Emergency Medical Care and Disaster Medicine selects the specialty hospital, dispatches a civilian EMC team, and confirm a free bed and team readiness. Third, accountability. Designated hospitals cannot refuse a targeted patient. They must keep 24/7 reserve bed and remain ready. Fourth, safety. If patient deteriorates in transit, the crew may divert to a pre-designated stabilization hospital along the road. The center communicates these backup airfields in advance. Why this is important right now? First, hospitals near the front are working at the limit of their capabilities. The flow of urgent patients is enormous. While the resources for the most complex reconstructive intervention and prolonged intensive therapy, there is objectively limited. Second, the risk of infection complication, especially due to multi-resistant flora, increases sharply with each additional stage and each extra bed in an overcrowded facility. Reducing intermediate hospitalization is not about comfort, it's about survival and result quality. Third, time is crucial. When we eliminate extra circles and take the patient immediately to where they can be operated on by profile, we gain hours, then convert into saved limbs, organs, functioning and sometimes lives. Unfortunately, there are patients whom even our best team cannot safely manage inside the country. We evacuate them to foreign clinics through Medevac Ukraine, a program run by Ministry of Health with the European Commission. It serves those directly affected by Russia's full-scale invasion from mine blast, shrapnel, and gunshot injuries. Evacuation begins in the hospitals where the patient is staying. From there, they are transported to Lviv by ambulance. Then, by ground transport, the patient goes to EU Medevac hub in Rzeszów. From Rzeszów, patient flies by specialized aircraft to the country of treatment, where the local team meets them and takes them to the hospital. So far, approximately 6,000 patients have been evacuated, about 4,400 of them service members, to nearly 30 countries, including Germany, Norway, Netherlands, Denmark, France, Sweden, and others. But the first duty is to save life, And the next is to return a person to the society, family, and work. This is rehabilitation. For the Ministry of Health, rehabilitation is not an optional extra. It's a flagship direction that we have been systematically developing since 2016, and that has now become an integral part of medical care. In peacetime, the country needs about 7,000 rehabilitation beds. Today, we have approximately 12,000 beds. There is spare capacity across the country, and the beds are not filled to the brim. At the same time, the strongest departments are overloaded because everyone wants rehabilitation specifically there. The conclusion is obvious. The problem is not square meters, but quality of care. Our strategy is not to build separate rehabilitation center for the sake of single board, but to raise the level in existing department, to invest in people, standards, mentorship, simulation, and clinical training, short internship and exchange. We need strong team in more places so that the patient receive modern rehabilitation quickly and close to home. We are deliberately building capacity in the conditions that drive the main demand: strokes, orthopedic lesions, as well as what the war has made a daily reality: traumatic brain and spinal cord injuries, multiple amputation, complex orthopedics damage, speech and cognitive disorders. For each of these areas, we are forming pathways, protocols, and team interaction. Rehabilitation today is fully integrated into the program of medical guarantees since 2022. The National Health Service of Ukraine has paid for inpatient and outpatient rehabilitation. The separate package operates for early rehabilitation of infants. This means hospitals have a clear payment model and patients have guarantees access to service without additional payment. Colleagues, at this stage, I want to clearly formulate our request to the professional community and partners. We are building a continuum of care from the battlefield to recovery, and we need allies to close critical gaps. The first is mild traumatic brain injury. This is among the most common combat injuries. Around 80% of TBI are mild, often blast-related, and too often missed. The problem is not only quantity, it's often underestimated. There is no striking wound, but there are long-term cognitive, behavioral, and sensory consequences. We ask for help building a network of mild TBI centers inside our rehab system, training optometrists, neuropsychologists, sleep specialists, and other specialists. The next is pain. We have already begun developing our national pain management program, and there will be a separate discussion about it today. At the same time, we need to keep the work going, improve team training, launch acute pain service in hospitals, provide equipment supply, and sustain mentorship in interventional analgesia. The next is infection control and multi-drug resistant infections. Evacuation routes are long. Sometimes a wounded person passed through 5-7 facilities. The seams between stages are most vulnerable to colonization and infectious complication. Partners who treated our patient via Medevac confirm the depth of the problem. Our request is specialized courses in IPC-EMR, help is setting up rapid microbiology, and contact precaution. The next is burn. Burn capacity is limited. We create national standards and have growing teams, but very deep or extensive burns still exceed in country capacity. So the most severe cases are referred to the facilities abroad. We will discuss this in more details tomorrow. We still need mentorship for core teams, targeted training, scholarship exchange, and help with educational materials. The next is trauma overall. First of all, scaling training. We need a leap in trauma care quality at every level. We need help to increase the volume of the training in trauma management so that later we will be able to make it mandatory. Our request is partnership for mass ATLS-like courses, TCCC, assistance in training in battlefield transfusion, damage control resuscitation, damage control surgery, ultrasound in trauma, and for building simulation centers and an instructors core in Ukraine. Separately, in the context of targeted evacuation, we need training for EMC crews to handle long-distance transport or severe ill patients. The number of such patient-trained crew is our limited factor. Trauma training for hospitals that receive this patient, and support for Center for Emergency Disaster Medicine and as a coordinator for grow its capacity. The next is research to save more lives tomorrow. For example, spinal cord injury as a result of war. Thousands of young patients have in Ukraine spinal cord injuries. We concentrate them in 7 designated facilities and are ready for multi-centered studies, registries, rehabilitation trajectories, assistive mobility technologies, and research that has the potential to help such people. The next very crucial needs is analysis of preventable death. We are ready to jointly launch a research project with a methodology that allow us to determine whether death was preventable, to combine trauma data with utilized data from the Bureau of Forensic Examination when it's ethically and legally permissible, to see the bottleneck of care and close them with solutions, not assumption. Ukraine pays a high price, including the lives of our defenders, and our moral duty is to turn every lessons and every loss into knowledge, protocols, and trained teams. Thank you everyone who already helped in Ukraine for trauma care training, for damage control surgery, from the first years of the war, for support in burn treatment, for advancing pain management services, for training reconstructive surgeons and organization medical mission to Ukraine, for the many humanitarian supplies, and for arranging exchange internship in the United States hospitals for Ukrainian doctors. But we need this support to continue and grow. And thank you everyone who is ready to join this work. Together, we will not only improve treatment outcomes in Ukraine, but researching and analyzing the Ukrainian experience, we will reduce human losses wherever blood is shed and be better prepared to save lives in the future. And let's keep for many years the spirit and motivation that we have today. Thank you.
Thank you, VASYL, for this wonderful talk. And it's impressive what you guys have been able to do in such circumstances. And I may ask you to just go back a slide or two just to show us what are the current needs. That's right. So this is great, just to leave that on the screen. And we have a few minutes for questions. And my, I guess, first question is actually to the audience. We see what the needs are from the Ministry of Health and from the folks who are in the audience. maybe we can at least start to get a sense of, who is able or interested in working on some of these topics. So let's say for traumatic brain injury, can I see some raised hands? I'll raise mine. Okay, great. So and this may be nice to know who's raising their hand so we can start actually chatting about how to solve these issues during our breaks in the coffee session or tea session, et cetera. And then pain management. I'm going to raise my hand as well. And then we have Andriy Strokany in the back. I know that you are available for this, so you can raise your hand. Great. And infection control and multi-drug resistance. Wonderful. So look around the room to see who's available for you to chat with. Burn medicine. Wonderful. Look at this. Nelia, are you sure you're able to do all these things?
I am skipping pain management.
Yeah. Okay. All right. Okay. And then trauma training, ATLS. Oh, look at this. That's wonderful. Okay. So it should be a very nice and productive session. And then spinal cord injury research. Okay. Excellent. So you have a few folks who might be interested in doing that. And so any questions you guys have for VASYL after this talk? Yes, please.
Tell us a little bit more about fresh frozen plasma and walking blood banks,
Great.
and its relationship to hypothermia and the clotting cascade.
Mhm.
As we know, with lower body temperature, the clotting cascade sort of starts to dissipate. And with full-on field care, what measures are being taken, or how can we help to prevent those deaths?
Great. So I'm just going to repeat the question for those in the audience online. And so the question is asking VASYL to tell us a little bit more about the frozen fresh plasma and blood products that are being delivered to the front line in the context of hypothermia and how that might influence the clotting cascade, and what are some of the paths forward in this direction.
If you talk about frozen fresh plasma, it's not too easy to supply this plasma, and usually on the battlefield we use dry plasma. The Germany Red Cross supply us with dry plasma, and our combat medics use this. Frozen plasma can use in the case that we saw when by, for example, drone delivery, or in the role 2, for example. In this setting, they have possibilities to storage frozen plasma and use this. If you talk about walking blood bank, it's illegal for Ukraine, but this used in mostly in the special forces, because each defenders know their blood type and know the blood type their friends, and it's used in these circumstances. But we try to increase using whole blood, like also in the role 2 and role 1, because not every stabilization point use blood components, and for the examples like Azov or First Medical unit, I think, yeah. Also the other progressive brigades used whole blood, and not only whole blood, but like blood components. But if we compare different brigades or corps, we saw that in some brigades the supply of blood is very high, but in other brigades, in the same circumstance, they ask us for about a low amount of the blood. So we should standardize this approach. And the next question was about
Hypothermia and the prolonged
oh,
evacuation.
it's problem. When our friends analyzed the cause by death, they saw that even not so severe hemorrhage combined with hypothermia caused due in the to death. It's problem, but there we need additional like supply in some heater in the center.
Thank you very much for your talk. For a lot of us, we're aware of funding opportunities from MTech and various things to try and contribute. Which, if those sorts of extramural routes are unsuccessful, but the organisation still has resources, how do we actually, I appreciate step one is turning up today, but how do we communicate what we can contribute to yourselves?
Okay. Okay, if we talk about our cooperation with MTech, we have cooperation with MTech, and for now we have discussion about making the research in preventable death, which I mentioned. We want to establish like a consortium to do research in our Bureau of Forensic Medicine, and we try to identify which is how we can manage with the preventable death, which injuries goes to the preventable death, and etc. And also we have some other like research project in MTech, but it's different. For example, Pan Brezuk have project with MTech, I think, and some in mental health. Like trauma registry, it's just like a small project in the 4 or 3 facilities funded by MTech, which try to gather data in trauma. But
how can we, is there a centralized way where one can communicate and say, we have these resources, they are at your disposal, or how can we help?
we can like also establish consortium, for example, Harvard, Brigham, and some NGOs, together with Ukrainian side, and with support of the Ministry of Health. We, like as the Ministry of Health, we can approve that what is our priorities, what we need, and go to the, in this case, to the U.S. government about tech funding.
Yeah, I have kind of an administrative question to you. Trauma partnership in Mass, ATLS and TCC. So there's a lot of volunteers that want to help and so forth, and a lot of people doing different type of trainings. I just work with the medical corps more. So I really have not worked with the Ministry of Health on this subject. So if we're going to be organizing this partnership, who should be running it? Military or the Ministry of Health?
I think both. It depends. On my opinion, everything what can be done by the civilian system should be done by civilian system. If you talk about ATLS, we need ATLS not only for military guys, but for all system. And our civilian doctors, they today they are civilian doctors. Tomorrow they will be military doctors. And we work like in the unified medical space. And for example, more than 85% of wounded soldiers receive treatment in the civilian system. So I don't divide this for like for civil. Yes, we have tight, good coordination with the military. Really work like one team.
Thank you, VASYL, first of all, for everything that you do and for the great presentation and for sharing the insights. One question I have is that mental health is part of a lot of things that are the need in Ukraine, and it accompanies a lot of these issues. What are some needs in mental health treatment, especially for war veterans?
It's complex questions. for me it's easy to talk about physical rehabilitation because we have a clear structure, we know what we do, we establish already network. With mental health, we not move so far like in the physical rehabilitation. And I think that, for example, Oleg Berezuk in his panel talk more about this because like, please.
Yes, Erwin.
Just a quick question. First of all, we have been involved in bringing some Ukrainian physicians to New York for Montefiore Medical Center. And a point I want to make is that it has been a two-way street of learning and teaching. This is the doctors at Montefiore Medical Center, where we brought Ukrainian physicians, have actually pediatric subspecialists, have been teachers, not just learners. It's been very much a cooperative situation. But I wanted to ask you a very specific question. The issue of, it's related to what this gentleman asked, the issue of military versus civilian medical systems. When there's fighting in, well, highly populated areas, and civilians come, into the sort of line of sight of the military positions, does the military system accommodate the management of civilian injuries, for example, as much as the military troops?
Yes. For example, if we talk about city directly in the front line, the military doctors accommodate both,
Okay.
and civilian and military personnel. The same in the civilian hospital, we also accommodate both
Okay.
civilian and military personnel.
That's wonderful. Thank you so much, everyone. Just to stay on schedule, we're going to move on. VASYL, thank you for your perspective and for collaboration.